Good morning, dear students. The aim of I'd like first of all to introduce myself. I'm Professor Ana Aburaya. I am a professor of rheumatology and internal medicine, and I'm head of the rheumatology division. What we'd like to be doing today is to familiarize you with a clinical approach to a patient having systemic sclerosis. The broader term is scleroderma. But what we want you to know for the clinical round is the precise term systemic sclerosis. Of course, like anything in rheumatology, we can only reach a proper diagnosis, if not a definitive diagnosis, a provisional diagnosis, sometimes in up to 95 to 100% of our patients, by taking a good history. So history taking is of the utmost importance in all specialties in medicine, and in particular in rheumatological diseases. So today we have with us Mrs. كوثر. السلام عليكم، صباح الخير أستاذة كوثر. احنا هناخد بعد إذن حضرتك شوية دقيقة من حضرتك، نسأل حضرتك شوية أسئلة وبعدين هنكشف على حضرتك. الأول عاوز أسأل حضرتك، عندك كم سنة أستاذة كوثر؟
عندي داخلة 60.
ربنا يديك الصحة. 60 سنة. وأنت متجوزة؟ وعندك كم أولاد؟ 4 أولاد. زي الفل. وحضرتك ست بيت. تمام. الشكوى ابتدت من إمتى يا أستاذة كوثر؟
من 24 سنة.
من 24 سنة. الشكوى اللي ابتدت من 24 سنة لسه موجودة حاليا؟
لسه موجودة.
ايه كان اول شكوى ابتديتي بيها؟
اول شكوى ابتديت بيها الزرق والتنميل، ايديا كانت بتزرق وتنمل.
الاطراف كان بتزرق وتنمل، اطراف الايدين والرجلين، خصوصا في
الشتاء. بتزيد اكتر في الشتاء.
كان بتزيد اكتر في الشتاء.
اليد الاول تزرق، اما بدا فيها بتحمر.
وده ابتدى من 24 سنة وموجود مازال إلى الآن. So we have a complaint. The presenting complaint in our patient here is bluish discoloration of the tips of the fingers and the toes. And this has been present for 24 years, but it is still present to date, and that is why we add it in the complaints. 24 years duration. كان بيحصل تلميل برضو يا أستاذة كوثر. تلميل associated with tingling and numbness, and this is especially in the cold winter months. ايه اللي كان بيحسن التلميل ده أستاذة كوثر؟
لما كنت بكتة كانت بتتحسن لما في مع البرد الجامد.
وفضلت الشكوى دي مع حضرتك كذا سنة.
ما هو زي الموجودة
وموجودة. أما الشكوى دي ظهرت من 7 سنين، من 24 سنة إلى الآن. حضرتك رحتي الدكتور؟
رحت الدكتور أوعية دموية.
ساعتها رحتي دكتور أوعية دموية، وقال لك إيه؟
قال لي عايزة عملية بتر عصب اللي هو العصب السمبثيك. فطبعا ما عملتهاش على طول، قعدت 7 سنين. الشكوى الوحيدة زرق وتنميل وما اتحسنتش. رحت لكذا دكتور وما فيش حاجة.
يعني 7 سنين الشكوى الوحيدة كانت الزرقان. وبعدين يا ست كوثر
بعد 7 سنين من التعب رجعت لنفس الدكتور. قال لي هو علاجك الوحيد العملية. عملت العملية في بداية 2002. عامل لي ايديا الاول وبعدين رجليا، كان عاملها لي في البرد. طبعا الصيف ما بشوفش الزرق كتير. اول الشتاء ما دخل لقيت الزرق موجود زي ما هي وما اتحسنش.
يعني العمليه ما حسنتش الزرقان؟
لا ما حسنتش حاجه.
ايه اللي زاد؟
اللي زاد شد الجلد.
شد الجلد. الشد الجلد كان بعد الزرقان ب7 سنين.
بعد العمليه.
ابتدى فين شد الجلد يا استاذ؟
ايديا.
في ايديكي الاثنين؟
الاثنين. وفي وشي. وبدأ في رجليا. ابتدت تظهر بقى الاعراض دي على وشي والسنان تلم. وطبعا بقى يجيني قرصص في صوابعي، يجيني غرغرينه. وطبعا بعديها جاني صعوبة تنفس. صعوبة
لا احنا مش عايزين نجري كده. اما حصل بقى شد الجلد والكرح في الايدين، رحتي للدكتور ولا لا؟
رحت له بس ما شخصنيش.
ما شخصش برضه. بالرغم كده ما خدناش اي علاج الفتره دي كلها.
كنت باخد موسع للشرايين بس ما كانش بيأثر معايا.
وبعد ما خدتيش علاج ولا اتشخصتي. امتى بقى حصل ايه بعد كده؟
حصل بعديها ان انا جاتني صعوبه في البلع.
صعوبه في البلع.
جاتني صعوبه البلع، تحولت طبعا للروماتيزم، شخصوني. وجاتني صعوبه تنفس.
صعوبه البلع دي كان للقمه الناشفه ولا للميه بس؟
لا للاكل.
للاكل. وكان بتزيد معاكي ولا هي مستمره؟
لا كانت بتزيد بقى لما خدت بقى العلاج يعني
اتحسنت. مع صعوبه البلع دي في اي اعراض تانية؟
في الحرقان في المعده، عندي احساس بالترجيع دايما
في فم حرقان.
وعندي يعني على طول يجيني زي ارتجاع. وعندي تملي بطني دي مشدوده.
يبقى حصل وجيتي عندنا هنا في القسم الروماتولوجي، وساعتها عملنا تحاليل وشخصنا حضرتك. ايه اللي اخدتي العلاج؟ اتحسنتي بالعلاج؟
والله يا دكتوره برضه يعني شويه كده، بس برضه
بتحسي ما زال في اعراض. ايه اللي زاد في الاعراض؟
اللي زاد صعوبه التنفس.
مع المشي،
مع اي مجهود،
مع اي مجهود بسيط.
مع اي مجهود، لو مجهود بسيط برضه بيجيني.
بس ما فيش الام في الصدر؟
لا في ساعات بيجيني الم في صدري.
في فم نتيجه ده، يمكن نتيجه هنشوف كل حاجه.
حاجات في القلب كده، تيجي لي كبشه كده، ينزل الم من هنا، الناس سمع في دراعي.
ده بقاله قد ايه يا ست كوثر الالم؟
يعني بقاله زي اكتر من 10 12 سنه.
10 12 سنه. وخدت بتاخدي ما زال بتاخدي علاج، بس برغم العلاج بتحسي حضرتك اللي ايه الحاله؟
وزني قل، ابتدى عينيا فيها زي رمله. رحت الدكتور يعني طلع لي نضاره. طبعا شعري ابتدى ينزل. في اماكن فاضيه في شعري خالص. اخر حاجه
المفاصل،
الام في المفاصل كلها.
في الام في المفاصل في جميع المفاصل.
كده
دي ابتدت امتى الام المفاصل؟
الام المفاصل دي لها بتاع 10 سنين معايا.
10 سنين معايا.
وثابته.
والحركه قلت.
الحركه قلت جدا.
تمام. في اي حد تاني في العيله عنده نفس المشكله؟ ما فيش. في اي ادويه بتاخديها غير الادويه اللي احنا بنكتبها؟
بتطلعها لي
بس. طيب. Okay, so now we are confronted, if we want to sum up the history, we've got a female patient that is 50 years of age. She is married and has 4 children. She has been complaining for about 24 years. Her complaint started with bluish discoloration of the tips of the toes and the tips of the fingers, toes and fingers on exposure to cold. This symptom is what we call Raynaud's phenomenon. It's a very important symptom, and it is the presenting feature in 98% of our patients. So the medical term is Raynaud's phenomenon. We have to know this feature very well, because we should know that Raynaud's phenomenon may be primary or it may be secondary. If it's primary, it's what we call Raynaud's disease. It's idiopathic. This is not what our case is. Our case is a case of secondary Raynaud's phenomenon. And this is the most important presenting symptom in patients having systemic sclerosis. So keep in mind that secondary Raynaud's phenomena is due to connective tissue diseases. Amongst the most important connective tissue diseases that present with Raynaud's phenomenon is systemic sclerosis. It's not unique to systemic sclerosis. Raynaud's phenomenon can occur in systemic lupus. It can occur in rheumatoid arthritis. It can occur in other connective tissue diseases, polymyositis and dermatomyositis. It can occur due to other causes, drug intake. For example, that's why I asked her about other drugs. It can be due to beta blockers, ergot drugs, etc. It can be due to hematological conditions. But here, it's the presenting feature of our case. So, if we ask you what is Raynaud's phenomenon? Raynaud's phenomenon is a peripheral vascular disorder. We should all know that. It presents by episodic discoloration of the tips of the fingers and the toes, maybe the nose and the ears as well. in which we get 3 color changes. First of all, the hands become white, as Mrs. Kausar said, and that is due to the vasospasm. Then they become blue, that is because of the sluggish circulation leads to peripheral cyanosis. The redness is due to the reactive hyperemia that occurs, and at that time she feels tingling. She said she has tingling in her fingers. That is because of the accumulation of the metabolites, which leads to stimulation of the nerve endings. So here, Kausar presented in the classical way, Raynaud's phenomenon. But the thing is that you should note in the history that Kausar sat for 7 years. Her only complaint was Raynaud's phenomenon. She didn't complain of anything else. And that is why she was undiagnosed. And that is why when your patients present with Raynaud's phenomenon, from the beginning, we should find out, is it primary or is it secondary? And as we will be discussing later on, primary is idiopathic. It's not due to any underlying condition. And therefore, when we do the ANA as a screening test, it will be negative. When we do the nail fold capillary microscopy to see if there are any abnormal folds, it will be normal. Whereas in secondary Raynaud's phenomenon, due to systemic sclerosis, the ANA might be positive, the anticentromere might be positive, and there will be abnormal nail fold findings. That's for the beginning. Going back to the history, we said we have the bluish discoloration, and Kausar then complained, she said, of thickening of her skin. But that took 7 years later. That was 7 years later. So 24 minus 7 is how much? 17 years. Thickening of the skin. Tightness of her skin. She said of her hands, feet, mostly, and then she also noted facial changes in the color of her face. الجلد بقى أغمى مش كده يا كوثر؟ She has tanning of her skin. She's got a rash, which, as we'll see later on, will be due to telangiectasia, as we will speak about. So that is the thickening of the skin. We should always ask, where did it start? It started in the hands, bilateral, both hands, and it spread in an ascending manner, and in the feet as well. Then she started to complain of digital ulcers, which were repeated, and sometimes they were infected. Her following complaint was dysphagia. Of course, when you are confronted with a GIT symptom, we should ask about all the other GIT symptoms. In this case, she said her dysphagia is not progressive, it's only to fluids, it's only to solids, it's not to fluids. It's not associated with pain, there is no adenophagia, and it's also associated with heartburn. This heartburn is due to the gastroesophageal reflux disease that these people get. I will be discussing that in a minute with you. Let's go back to the symptoms. Finally, she is also complaining of dyspnea, which is progressive, arthritis, generalized polyarthritis, mainly in the large joints and also sometimes involving the small joints, and she's got limitation of her motion in general. So this is her history. If we ask about the past history, there is nothing which is relevant or significant in this situation, but we should always make sure that we ask about any previous operations. She, as we said, after she got the bluish discoloration, she went to a vascular surgeon because they get misdiagnosed, and he did a cervical sympathectomy. Of course, she did not improve. On the contrary, she started, after her condition got worse, thickening of her skin, and then she also got facial changes. So her condition was progressive, and that is why the old term used to be progressive systemic sclerosis. We don't use this term anymore. If we want to collect the pertinent data, it's bluish discoloration, it's skin tightening, it's dysphagia, not to forget the digital ulcers, it's heartburn, dyspnea, polyarthralgia, sometimes arthritis, and general limitation of her motion. And this condition is progressive, and it's going on for 24 years now. When you're confronted with such a patient, we want to collect the data. What do we note? We note that we have a multi-system autoimmune systemic disease. We have skin involvement, Raynaud's phenomena, GIT involvement, respiratory involvement, maybe cardiac involvement according to the history of the patient, and also arthritis. So multi-system connective tissue disease. What can bring all this about? Scleroderma. So this is our diagnosis. Of course, we are not dealing with the localized scleroderma. This is not our topic today. This belongs to dermatology. We are speaking about systemic sclerosis. Systemic sclerosis is a multi-system autoimmune connective tissue disease that is characterized by affection of mainly the skin, the GIT, the respiratory system, the cardiovascular system, the nervous system, and any other organ in the body. And of course, not to forget the renal system. The second question that we should ask when we're confronted with our patient is, what is the type of systemic sclerosis? What is the type of systemic sclerosis? So, systemic sclerosis may be limited or diffuse. These are the two important types. How do we diagnose that? The first thing that we should note is that limited cutaneous systemic sclerosis involves the skin distal to the elbows and distal to the knees. So when we come to examine, as we will do in a minute, I can even do it now. معلش بعد إذن حضرتك. أنت البسي الماسك، أنا مش هلبس ماسك. ماشي. Okay, so the first thing we want to do is we want to pick up, is it limited or diffuse? So we start at the extremities and we start pinching the skin. Okay, okay. The skin tightness is below the elbow. Above the elbow, it's normal. Above the elbow, it's normal. Okay. The same applies to the feet. We go, pinch, pinch, pinch. It's all normal. This is tight, tight, tight. But below the knee and below the knee, it's normal. Okay? So all here is affected. Above the knee, the skin is completely normal. So this is limited systemic sclerosis. Why do we make an emphasis for us to divide the limited from the diffuse, because it will vary in the prognosis as well. Just to bring things into perspective, I've taken the history, and the provisional diagnosis here is systemic sclerosis. If I want to complete the history, in rheumatology we've got something called ACR criteria for the classification of systemic sclerosis. The old criteria that we used to have gave us 1 major and 3 minor criteria. The first major criterion to diagnose a patient as having systemic sclerosis is that I should have sclerodermatous skin above the metacarpal pharyngeal joint. So I take my patient's hand and I go above the metacarpal pharyngeal joint. If the skin is tight above the metacarpal pharyngeal joint, okay, I can't pinch, then this is the first major criterion that my patient has got systemic sclerosis. Tight skin above the metacarpal pharyngeal joint. Then I have another 3 minor criteria. Sclerodactyly. Sclerodactyly means thick skin over the digits. It's present in my patient here. So that's criteria number 1, minor. Criteria number 2, minor, is digital pitting scars. I don't know if the camera can see this. Okay. Or loss of the finger pad substance. If you compare my hand, the pad substance to here, there is loss of the pad substance because there is no nutrition. The vasculature is affected. Okay. Criteria number 3 is bilateral basal pulmonary fibrosis, which we will examine when we do the internal organs. I need 1 major and 2 minor criterion to diagnose my patient as having scleroderma or systemic sclerosis. Here they are present. I've got sclerodermatous skin above the metacarpal pharyngeal joint. I've got sclerodactyly. I've got loss of the finger pad substance and digital pitting scars. I don't need any more. The second question would be to subdivide my patient into limited or diffuse. And as I said, the limited is skin involvement below the elbow and skin involvement below the knees. So the skin is tight just until below the elbow. So that's the limited systemic sclerosis. The face is always involved. Don't use the face to differentiate between limited and diffuse because that will confuse you. What we have is the landmark, the elbow and the knee. The upper part of the chest may be involved, even in the limited, but the whole of the trunk will never be involved except if it is the diffuse type. So it's very important from the beginning to diagnose that this is a case of systemic sclerosis from the history and from the clinical and from the criteria, and then to subdivide into limited or diffuse. Why is it important to subdivide into limited or diffuse? Because, as we say, the prognosis. In the limited type, as is in the case of Kausar, she had Raynaud's phenomenon for 7 years before she started to complain of tightness of her skin. In the diffuse type, Raynaud's phenomenon lasts for about 6 months, 1 year maximum, and quickly she gets skin tightening. In the limited type, the organs are affected. At the end, they will be affected in the same way, but in the limited, we first get pulmonary artery hypertension as a complication, whereas in the diffuse, we will get interstitial lung disease as a pulmonary complication. In the limited type, we will get the antibody called anti-centromere antibody, whereas in the diffuse, it will be the anti-scleroderma 70 or the anti-topoisomerase. Also, the severity. Diffuse is the severe form of systemic sclerosis. So, the main aim in the history is to analyze the symptoms very well and then move on to diagnosing your patient as having systemic sclerosis, and then move on to the third step to differentiate between the limited and the diffuse type. Do not forget also when we come to examine our patient, of course, we have to examine the hands in great detail. Of course, when I greet my patient, I realize that her hand is cold. She's got cold hand. Raynaud's phenomenon is not so evident now. If we look a little bit closer, we may find some bluish discoloration, but the hand is cold. The size of the hand is smaller than normal. There is evident sclerodactyly. There is resorption of the digits, as you see. There is tightness of the skin. The skin is taut. I cannot pinch it above the metacarpopharyngeal joint. There are areas of depigmentation and areas of hyperpigmentation, which is what we call the salt and pepper appearance, which is very classical in systemic sclerosis. There are areas of telangiectasia as well. There is nail dystrophy, as you see, and Kausar is unable to form a fist. So she has lost all her function of her hand. And this is due mainly to the flexion contractures that she has, not due to the joint affection. The joint affection comes secondarily. So her deformities here is due to the flexion contractures. If we look at the face, and the face is always very characteristic. The face here, as you see, the patient is more or less masked face. There are a lot of telangiectasia which are present all over the face. The nose is pinched, tight skin over the nose. The patient cannot open her mouth. She's got a very narrow oral aperture, what we call fish mouth. And the lips are very, very thin, if you see. And if you look inside, the teeth are in a very bad hygienic condition because she cannot introduce her toothbrush. And maybe it is associated sometimes with halitosis as well. Do not forget that there is also, to lift up the scarf and see that there is receding of the hairline as well, tightness of the skin, telangiectasia of the face, pinched nose. This is what we call scleroderma facies. In the limited type, there is a subtype that we call crest. It's a subtype of the limited. Crest. And that stands for calcinosis, Raynaud's phenomenon, esophageal dysmotility, sclerodactyly, and telangiectasia. So that's a subtype of the limited systemic sclerosis. Of course, it's very, very important that we examine the patient from top to bottom. We should always take the vital signs, the pulse. There could be conduction defects which could lead to arrhythmias. We should always measure the blood pressure in our patients because the renal involvement, thank God now it's rare, but these people can get what we know as one of our rheumatological emergencies, scleroderma renal crisis. It's a rheumatological emergency and we should keep it in mind. So always measure the blood pressure, take the temperature, it's important as well. And also, when we examine the internal organs, we should go to two systems in particular. We should always examine the respiratory system. Bilateral basal pulmonary fibrosis is very important. We should also always examine if there is any pulmonary artery hypertension. And for further accuracy, we always do, if we suspect pulmonary artery hypertension, we do an echo, and if we suspect interstitial lung disease, we do a CT of the chest. That's what I want to say. The GIT system is very important as well. We should always take care of that and do the necessary investigations. So after taking the history, after examining our patient, what are the investigations that we need? That has been spoken about in the lecture, but the main investigations include the autoantibodies, anticentromere for the limited, anti-scleroderma for the diffuse, ANA, we do GIT, maybe a barium swallow, we may also do manometry, ECG, etc. Is there a cure for this disease? There is no cure. There is no cure for systemic sclerosis. We treat the organs. So we have organ-based therapy. The patient is complaining of Raynaud's phenomenon. We tell her always to wear gloves. And as you note, even now, she's coming with her gloves. Okay? And she's always wearing mittens as well. She should never touch anything cold. If they are smokers, they should stop smoking. And we also have medications such as calcium channel blockers. For the heartburn and the dysphagia, we give prokinetics and proton pump inhibitors. For the lung affection, there are now new drugs that are available as well. Always measure the blood pressure, and if it is increasing, we give prophylactic ACE inhibitors. Okay? We want to thank our patient. نشكرك يا أستاذة كوثر على وقتك وعلى مجهودك وربنا يشفيكي ربنا يخليكي. شكرا. This is just a very quick recap. I won't go through all the slides, just to highlight the pertinent data that I want you to know for this clinical approach. So if we ask you what is systemic sclerosis, it's a connective tissue disorder that is characterized by multi-organ manifestations. It's a chronic multisystemic disorder. The etiology to date is unknown. What is the cause of all the symptoms that we saw and the signs? 3 important factors: excessive fibrous tissue deposition, abnormal immune system, and vasculopathy. Etiology is unknown. Keep 3 words in mind: tissue fibrosis, vasculopathy, and abnormal immune activation. So why did our patient get Raynaud's phenomenon? Because of the vasculopathy and the fibrosis. Why did she get dysphagia? Because of excessive fibrous tissue deposition in the esophagus. This is the classification that we spoke about: limited cutaneous scleroderma and the diffuse. There are other types which are rare. Also, the localized does not concern us. Keep in mind that the diffuse means that there is skin thickening above the elbow and above the knees. This is a table that is very important for us to differentiate between the limited cutaneous and the diffuse cutaneous systemic sclerosis. Skin involvement, Raynaud's phenomena, the duration of the Raynaud's phenomena, the lung affection, the scleroderma renal crisis, which is commoner in the diffuse. So the table is very important. These are the old criteria which are quite helpful in clinical practice because they make you diagnose your patient. But these criteria are late, and that is why in your lecture you were given new criteria, because we want to diagnose our patients quicker. This is the classical signs that we see, the picture. This is the very beginning, the puffy fingers, the puffiness, and then we move on to the atrophic phase and the digital ulcers. The X-ray findings, always keep it in mind. Putting everything in perspective, the mouth, the fish mouth, the radial furrowing that you see around the mouth as well. This is the new criteria. It's given to you in the lecture. We won't go into the details. Keep in mind, if we ask you what is the presenting feature of a patient having systemic sclerosis, in 95 to 98% of your patients, it's going to be Raynaud's phenomenon, the classical Raynaud's phenomenon. And then we move on. This is the classical picture. We don't need to have all 3 colors. We just may have pallor or the fibrosis. Okay? And differentiate always between the primary and the secondary Raynaud's phenomenon. I think this is what I want to end. I don't want to continue anymore. This is the nail fold capillaroscopy, and these are the digital ulcers, the necrosis, the calcinosis that wasn't evident in our patient, but many patients may have it. The skin involvement we spoke about. These are the phases. This is the puffy phase, and then we move on to the atrophic phase. Before that, we have to pass through the very long phase, which is the indurative phase. The indurative phase. Most of her life, our patient will live in the indurative phase. Towards the end, she will have the atrophic phase. Okay, I want to end it here.